past 5 years, we have seen a lot of some improvements and some drawbacks actually in the field of sickle cell disease. The major one has certainly been the development of 2 gene therapy for patients with sickle cell disease. And this is a very interesting topic, which I'm really glad you're asking me about, because the remarkable effect of the gene therapy in sickle cell disease is not so much the availability to this remarkable therapy to many patients, but it's the fact that has brought sickle cell disease to the forefront of news outlets. Interviews on NPR, the New York Times, so that the awareness of the disease has increased dramatically in the United States, where I spend most of my working time, but also worldwide. So this is something that we don't think about. Like a side effect almost of gene therapy is the fact that now everybody knows about sickle cell disease. Many drug companies are interested in sickle cell disease. The patient population is being educated about sickle cell disease, and many patients come to see now a hematologist because they're interested in this new therapeutic option. Many of them will not be eligible for this therapy, but they will receive other therapies. So the fact that they come to us is a major advancement in the therapeutic approaches to patients. The other thing is that we have developed more standardized care approaches to patients with sickle cell disease, because you cannot do gene therapy to a patient who has not received standard of care, right? You have to elevate the care to the patient, then you can intervene with gene therapy. So these 2 things, awareness and improvement of the standard of care of sickle cell disease, I think have been 2 major advancements in the past, I would say 3 to 4 years. Gene therapy improves outcomes in 2 major ways. One is, of course, for the patients that receive gene therapy, right? So we have seen a major improvement in acute events, mainly, sickle cell pain crisis. But the second reason why gene therapy has improved the outcomes is because, as I said before, the awareness of the disease in the general public and in the general population, and from physicians. So many patients are not seen routinely by a hematologist, right? They're seen by primary care providers or GPs if you are in the United Kingdom. And now these patients have been referred to the centers where the hematologists are, and they can propose other therapies if they don't qualify for gene therapy. It is really a very small amount of patients that really qualify for gene therapy the way gene therapy is today. Of course, we are looking forward to the day in which gene therapy will be given in vivo, which means without having to extract the stem cell from the patients, modify them in vitro, and then return into the patient. But we are looking forward to having in vivo gene therapy and to abolishing the conditioning regimen. The conditioning regimen is the one that uses myeloablative chemotherapy, which is a downside of gene therapy. As you said, many patients are not going to be eligible, at least not at the moment, the way gene therapy is done. I would say the vast majority. They have to be young, they have to be relatively free of end organ damage, they have to be willing to accept probably infertility as a result of this therapy. So you can understand many young people may want to have a family, so they have to have extensive testing and procedure to preserve fertility in the future if it is possible. But other therapies that are available, at least in the United States, is of course hydroxyurea, which is becoming more and more used by patients and providers. We still have availability of crizanlizumab, albeit not used as much maybe as was used in the past, but it's still used for patients that have a high burden of vaso-occlusive crisis. And there is L-glutamine, which is also used as a disease modifier. But I want to take this opportunity to just say something about the importance of standard care, which means supportive care. It is not just disease-modifying therapies that improve the lives of our patients, but this the standardization of supportive care, such as IV fluids, blood transfusions, chelations, therapy for their kidney disease. This is really what makes a difference in the longevity of our patient. If I might put a plug for the importance of comprehensive, competent, consistent, and cost-effective care. These are what I've defined the 4 C's of therapy for patients with sickle cell disease. Absolutely. Hydroxyurea is still the standard of care, and we still are underutilizing, and I do not see in the near future that we will be stopping using hydroxyurea. There are a number of molecules in development. We have many that aim to increase hemoglobin F, oral hemoglobin F inducer. There are at least 5 or 6 in various phases of development, and those hold a lot of promise because we all know that hemoglobin F is the #1 genetic modifier of sickle cell disease phenotype. And then there is, of course, the PKR, the pyruvate kinase activators. That there are 2 of them in development, and we look forward to the results of the phase 3 study for the mitapivat and the phase 2 for the etapivat. And both of them hold a lot of promise in this patient population.